Hi, this is Dr. George Rogu from RBK Pediatrics. I'm here today with Dr. Scott St. Amour and our medical student Brain Tang from NYIT. He's one of the students that rotated at RBK this month. He was an excellent student, and he's going to present some stuff for us on neuroimaging and with children with head trauma. Dr. Scott?
Hey guys, nice to see you. Thank you for taking a few minutes to listen to us. One of the most common complaints we get in our clinic are kids falling and hitting their head. One of the topics we concentrated on, Brian and I, was talking about what to do when a kid falls and bumps their head. So we put together this little presentation for you, and hopefully you learn some stuff. So take it away, Brian.
All right. Hi, everyone. My name is Brian. As Dr. Rogu and Dr. Scott mentioned, I'm a third-year medical student at NYIT College of Osteopathic Medicine. And for this video, I'll be talking about the indications for neuroimaging in children with head trauma, basically under what circumstances after head injury that neuroimaging is recommended. As you may be aware, children tend to be very curious and can get injured very easily. And one of the most concerning injuries is to their head and their brain. So to start off, I would like to talk about what traumatic brain injury is. Basically, it's an acquired injury to the brain that can be resulted from bumps, blows, jolts, or penetrations to the head. And this could lead to disruptions of normal brain function and behavior, and it all depends on whether the injury to the brain is in one area or throughout.
Yeah, exactly. Remember, the brain is like any other part of our body, and it can get bruised and damaged too.
All right. Yeah. So how would a physician determine if neuroimaging should be done after a child has a head injury? Well, after a trauma, doctors tend to assess for the likelihood of possible brain damage, which can be categorized as mild, moderate, or high risk. And these categorizations are based on a variety of symptoms that a child may or may not have and their level of consciousness. And based on the risk level, a doctor can consider if neuroimaging should be performed. So as I mentioned in the previous slide, one of the factors to determine risk of brain injury is the level of consciousness. It can be measured using a common scoring system known as a Glasgow Coma scale that, according to research studies, it has a good correlation with outcomes of head injuries. As you can see on the left-hand side, the GCS depends on three different behaviors: eye-opening, verbal, and motor responses. Now, depending on the amount of each response, a score is assigned to each behavior and then added up to form a total GCS score. A score of 15 indicates best response and better outcomes, and a lower score would be more concerning.
Yes, exactly. So remember, we don't decide which kids are at higher risk just completely arbitrarily. And that's one of the tools that we use to help us decide whether a kiddo needs a higher level of care, whether we need to look into anything or not.
Yep. All right. Now we'll move on to talking about the mild, moderate, and high risk of brain injury and how it's determined, as I mentioned before. So for children's 3 months and older, if there was a fall less than 3 feet, or if they have a GCS score of 15, as I mentioned in the previous slide, which is a good total score, and the higher the score, the better the outcome. So if there's absence of any of the following, such as altered mental status, skull fracture, vomiting, severe headache, seizure, or abnormal behavior, if this is the case, they fall under the mild risk category and no neuroimaging is needed. The child can be discharged home with anticipatory guidance, which means addressing any emotional or psychological issues associated with the trauma.
And remember, altered mental status is anything from slurred speech to not understanding what you're saying to speaking oddly, anytime the kiddo's not acting like themselves.
So now for moderate risk, there are two age groups, infants less than 2 years old and children greater than or equal to 2 years of age. Once again, for moderate risk, the GCS score of 15. If they are infants, They are considered moderate risk for a brain injury if they present with one or more of the following, such as loss of consciousness, a fall from a height greater than 3 feet, bruising on the head, basically blood collection, drowsiness and irritability, and also any like vomiting. As for the second group, in older children, so 2 years old or greater, if they present with also a loss of consciousness, a fall greater than 5 feet, and severe headache. If this is the case, doctors tend to observe the child for 4 to 6 hours, and if there are any worsening of the severity of the signs and symptoms, then neuroimaging may be warranted.
The take-home message here is if that there's any loss of consciousness, anyone's passed out from the head injury, fainted, anything like that, always bring them in to get checked out. If it was a fall from a height, always bring them in to get checked out. If there's headaches, vomiting, any other symptoms like that, bring them in to get checked out.
Now, there is a common event that happens with children that fall. They almost always vomit because they get very agitated and scared. So a one-time vomiting episode doesn't necessarily mean it's a severe, moderate to severe injury. But if they vomit numerous times, 5, 6 times, one after the other, that's a problem.
And as always, if you're not sure, bring them in and get them checked out.
Yep. For a GCS score of less than or equal to 14, with any of the following symptoms below is considered for high risk of brain injury. And these symptoms include severe altered mental status, skull fracture that can easily be felt when you touch the child's head, fracture of the base of the skull, which is also known as a basilar skull fracture, and like with bruising around the eyes, seizures that I guess resulted from the brain injury, and bulging fontanelle. Under these circumstances, neuroimaging is highly recommended and should be performed.
So these are the kids you're going to know it when you see it. They need the emergency department. So any altered mental status, like we talked about before, losing consciousness, slurred speech, palpable skull fractures, you can't miss those. Those are big lumps on the head or dents into the head too. Any of these are big red flags. Call an ambulance immediately.
All right. So there are different types of neuroimaging techniques, and it can be classified into 2 different types broadly. So it's structural and functional. Structural imaging techniques provide information about the anatomy of the brain and the surrounding structures, basically telling us what the head and brain looks like. This includes ultrasound and CAT scans, while functional imaging techniques provide information about the metabolism and how the brain is working. And nuclear medicine techniques like PET scan falls under this category. And lastly, but not least, MRI, also known as magnetic resonance imaging, it actually has best of both worlds, providing us with both structural and functional information.
This is all about what you're looking for. You need the right scan for the right thing. So when you're looking for damage and bleeding in the brain, you need a different scan than when you're looking for tumors or bones or anything like that. And that's the purpose of this slide here. Go on, Brian.
Yep, exactly. So I'm going to actually go into more detail about each of the neuroimaging methods that I mentioned beforehand. So for ultrasounds, they use sound waves, and these waves, when they hit your body, they bounce back and is recorded by the machine. And one of the biggest pros about ultrasound is that it's highly accessible, it's portable, and it's fast, and it requires no radiation for the child. On the other hand, CT has radiation. It basically is a series of X-ray images that is taken at various angles of the body, and it provides higher resolution of bones, blood vessels, and soft tissues. And then for the MRI, there's no radiation involved. It uses strong magnetic fields along with the body's natural magnetic properties, and it provides more sensitive and specific imaging information in comparison to the other two that I mentioned. The downside of the MRI is that it's more expensive. So if we could get a CT or ultrasound, it will usually be first or more ideal. And then if needed, doctors can move on to asking for MRI to be done. Lastly,
Brian?
yeah.
Which one? These are pretty sophisticated tests.
Yeah.
Which one of these is the most commonly encountered by a parent if they went to an emergency room?
The EM doctors tend to order either ultrasound or CT.
Right.
Ultrasound is usually the initial test. It basically tells us if there's something wrong, and then if we want to confirm anything, we use the CT.
Right. Well, that's what you're going to be doing when you do your ER.
Yeah.
Yeah, remember, and there's no one test that's strictly better than any other test. It's all about what you're looking for and why you're looking for it. And that's how doctors choose which test they're going to use for any given thing.
Yep. So lastly, nuclear medicine, they use radio tracers that are taken up by the cells and tissues. And there are two different types that I looked up particularly, PET scan and SPECT scan. One is more expensive, one is cheaper, one has better resolution, and one has poor resolution. So with the price comes the quality of the resolution. So for neuroimaging after trauma, usually a CT or MRI is performed. So before I move on to the next slide, is there anything you two would like to add?
No, you're perfect, Brian.
Okay.
Yeah, no, I think you covered all the basics, and I think you did a good job of explaining things for our parents at home. And I hope everybody out there who's watching this learned a little something today.
Take it on home, Brian.
All right, so I would like to give special thanks to Dr. Scott St. Amour and Dr. George Rogu, along with like everybody at RBK Pediatrics for making my pediatric rotation a wonderful experience. Thank you all for watching, and I hope everybody stays safe and healthy.
Thank you.
Right.
Thank you, Brian. Excellent job. Good luck in the future.
Thank you.